This recording will cover chronic pancreatitis. Chronic pancreatitis is a progressive, destructive disease of the pancreas that has remissions and exacerbations. Inflammation and fibrosis of the tissue contribute to pancreatic insufficiency and diminished function of the organ. Chronic pancreatitis can be classified into several categories. Alcoholism is the primary risk factor for chronic calcifying pancreatitis, the most common type. In the early stages of the disease, pancreatic secretions precipitate as insoluble proteins that plug the pancreatic ducts and flow of pancreatic juices. As the protein plugs become more widespread, the cellular lining of the ducts changes and ulcerates. This inflammatory process causes fibrosis of the pancreatic tissue. Intraductal calcification and marked pancreatic tissue destruction develop in late stages. The organ becomes hard and firm as a result of the cell atrophy and pancreatic insufficiency. Chronic calcifying pancreatitis is found predominantly in men, but the incidence in women is increasing. In women, chronic pancreatitis occurs more commonly among those with biliary tract disease. Chronic obstructive pancreatitis develops from inflammation, spasm, or obstruction of the sphincter of Oddi, often from cholelithiasis. Inflammatory and sclerotic lesions occur in the head of the pancreas and around the ducts, causing an obstruction and backflow of pancreatic secretions. Autoimmune pancreatitis is a chronic inflammatory process in which immune globulins invade the pancreas. Idiopathic and hereditary chronic pancreatitis may be associated with certain gene mutations. Pancreatic insufficiency in any type of chronic pancreatitis causes loss of exocrine function. Most patients with chronic pancreatitis have decreased pancreatic secretion and bicarbonate. Pancreatic enzyme secretion must be greatly reduced to produce steatorrhea resulting from severe malabsorption of fat. These characteristic stools are pale, bulky, and frothy and have an offensive odor. Fat malabsorption also contributes to weight loss and muscle wasting and leads to general debilitation. Protein malabsorption results in a starvation edema of the feet, legs, and hands caused by decreased levels of certain circulating albumin. The loss of pancreatic endocrine function is responsible for the development of diabetes mellitus in patients with chronic pancreatic insufficiency. The patient with chronic pancreatitis may have pulmonary complications, such as pleuritic pain, pleural effusions, and pulmonary infiltrates. Pancreatic ascites may decrease diaphragmatic excursion and lung expansion, resulting in impaired ventilation. In the ill patient with chronic pancreatitis, acute respiratory distress syndrome, or ARDS, may develop. Please review the chart in your textbook that lists the key features for chronic pancreatitis. Diagnosis is based on the patient's symptoms and lab and imaging. ERCP is done to visualize the pancreatic and common bile ducts. CT scanning, MRI, ultrasound, endoscopic ultrasound are also useful in making a diagnosis. In chronic pancreatitis, lab findings include normal or moderately elevated serum amylase and lipase levels. Obstruction of the intrahepatic bile duct can cause elevated serum bilirubin and alkaline phosphatase levels. Intermittent elevations in serum glucose levels are common and can be detected by blood glucose monitoring. Non-surgical interventions include drug and nutrition therapy. The major intervention for the pain of chronic pancreatitis is drug therapy. Medicate the patient as prescribed according to the assessment of the intensity of pain. Evaluate the effectiveness of the drug intervention. Initially, opioid analgesia is most frequently used. Pancreatic enzyme replacement therapy is the standard of care to prevent malnutrition, malabsorption, and excessive weight loss. See the chart in your textbook that has patient and family education regarding enzyme replacement therapy for patients with chronic pancreatitis. Pancrelipase is usually prescribed in a capsule or tablet form and contains varying amounts of amylase, lipase, and protease. Teach the patient not to chew or crush pancrelipase delayed release capsules or enteric tablets, and teach them to take the medications with all meals and snacks. The dose of pancreatic enzymes depends on the severity of malabsorption. Record the number and consistency of stools per day to monitor the effectiveness of enzyme therapy. If pancreatic enzyme therapy is effective, the stools should be less frequent and less fatty. If the patient has diabetes, insulin or oral antidiabetic agents for glucose control are prescribed. Patients maintained on TPN are particularly susceptible to elevated glucose levels and require regular insulin additives to the solution. Monitor blood glucose to control hyperglycemia. Check fingerstick blood glucose or sugar levels every 2 to 4 hours. The healthcare provider may prescribe drug therapy to decrease gastric acid. Gastric acid destroys the lipase needed to break down fats. Controlling the acidity of the stomach with H2 blockers and proton pump inhibitors, or neutralizing stomach acid with oral sodium bicarbonate, may enhance the effectiveness of pancreatic enzyme replacement therapy. Protein and fat malabsorption results in significant weight loss and decreased muscle mass in the patient with chronic pancreatitis. Therefore, the nutritional interventions for acute pancreatitis are also used for chronic pancreatitis. The patient often limits food intake to avoid increased pain. For this reason, nutrition maintenance is often difficult to achieve. Patients receive either TPN or TEN, total enteral nutrition, including vitamin and mineral replacement. Collaborate with a dietitian to teach the patient about long-term dietary management. He or she needs an increased number of calories, up to 4,000 to 6,000 calories per day, to maintain weight. Food high in carbs and proteins also assists in the healing process. Food high in fat is avoided because it causes or increases diarrhea. Teach all patients to avoid alcohol. Surgery is not a primary intervention for the treatment of chronic pancreatitis. However, it may be indicated for ongoing abdominal pain, incapacitating relapses of pain, or complications such as abscesses or pseudocysts. The underlying pathologic changes determine the procedure indicated. Using laparoscopy, the surgeon incises and drains an abscess or pseudocyst. Laparoscopic cholecystectomy or choledochotomy may be indicated if biliary tract disease is an underlying cause of pancreatitis. If the pancreatic duct sphincter is fibrotic, the surgeon performs a sphincterotomy to enlarge it. In some cases, laparoscopic distal pancreatectomy may be appropriate for resection of the distal pancreas or pancreas head. Procedures are performed through GI wall, Notes procedures, I should say. The natural orifice transluminal endoscopic surgeries are becoming more common. Procedures are performed through the GI wall without a visible skin incision. In a few cases, pancreas transplantation may be done. However, this procedure is performed most often for patients with severe, uncontrolled diabetes. Please review the care coordination and transition management portion on your own. It has some good patient education information that we want to be familiar with.